From the Journal of Nuclear Cardiology, this is JNC Cardio Connect, linking experts, insights, and innovations in nuclear cardiology. Let's dive into the next episode.
Welcome to this podcast for the Journal of Nuclear Cardiology. I'm Marcelo Di Carli, the editor-in-chief of JNC, and today I'm delighted to be talking with a senior author of a very interesting paper on monitoring quantitative responses to therapies for cardiac amyloidosis using technetium PYP SPECT-CT imaging. With me today is Dr. Sharmila Dorbala, who needs no introduction, but just to get the audience reminded, she is the director of nuclear cardiology at the Brigham and Women's Hospital. She's professor of radiology and medicine at Harvard Medical School, and she's one of the world leaders in quantitative molecular imaging of cardiac amyloidosis. So welcome, Sharmila, and thank you very much for joining us today for this podcast.
Thank you, Dr. Di Carli, for having me here. I'm delighted to be here.
This is a very interesting study. I thought that it built on some of your prior work on quantitative imaging. And although it has a relatively small number of patients, we thought that it was incredibly well done, and it really tweaked our interest in doing this podcast with you, and also picking on your brain on what might be the future work that needs to be done in this field. But before we get there, could you give us a brief summary of the motivation for undertaking this study?
Yeah, thank you so much. As you know, Shilpa Vijay Kumar was the lead author of this study. And I want to start off by saying that the field of transthyretin cardiac amyloidosis is really exploding with new treatments and new imaging methods. We now diagnose this condition predominantly using non-invasive methods, either technetium-99m labeled pyrophosphate, DPD, or HMDP. And stabilization of the transthyretin molecule using tafamidis has transformed the management of these patients by slowing disease progression and by improving survival and reducing heart failure hospitalizations, especially compared to placebo. Of course, now that we have targeted therapies, we now, for the first time, have the opportunity to evaluate myocardial changes at a molecular level using these bone-avid tracer compounds. There's some preliminary data in this area using DPD, which suggests that myocardial uptake of bone-avid tracers, DPD, can decrease with TTR stabilization or silencing therapies. But at this point, there are no data available using technetium-labeled PYP, which is a distinct but related tracer. And notably, most previous studies did follow-up imaging either at 7 months, 18 months, or 12 months, but our study looked at a longer duration of TTR stabilization.
Very interesting. So it seems like it is a natural rationale for what we need to do in the field moving forward, which is, like our colleagues in oncology have done for a long time, is there a way for us to create some readings of what may be going on with patients? So, tell us, who got into the study, and what was your study design to test this proof of concept?
Yeah, so this was a prospective longitudinal cohort study, and we looked at 23 patients who were all diagnosed with transthyretin amyloid cardiomyopathy, and all of whom underwent baseline PYP with quantitation, and also a repeat quantitative PYP, a median of 31 months after TTR stabilization therapy. So what we did in this study was looked at all the scans and graded them visually. We also performed quantitative analysis and measured SUV mean, SUV max, percent injected dose, and a metric called cardiac amyloid activity, which is a product of SUV mean times the volume of myocardium with amyloid. In addition, we also looked at baseline and follow-up echocardiograms and cardiac biomarkers in these patients. So the study showed four main findings. The first finding was a significant decrease in visual grade and a significant decrease in quantitative PYP metrics, specifically SUV max, percent injected dose, and CAA, or cardiac amyloid activity. Notably, in 8 patients in whom there was no change in visual grade, quantitative measures decreased significantly, suggesting that this may be more sensitive than visual grade for detecting change. There was also evidence of clinical and biomarker improvement in these patients. For example, serum transthyretin levels improved significantly, and New York Heart Association functional class also improved significantly. However, there was no significant change on echocardiography, especially global longitudinal strain, the National Amyloid Center staging, or NT-proBNP levels.
Very interesting. And I'm curious, do you think this is a unique finding that you made, or are there any other observations that may suggest that these signals that we're reading from the bone avid tracers are somehow disconnected with structural changes in the heart, or other markers of strain in the myocardium?
Yeah, this is actually a very important question because at this point, we really don't understand how these bone avid tracers are showing us amyloid in the heart. So the mechanism of uptake is not very clear. But the results of this study really open up exciting new avenues for research and really provide a new understanding of disease pathophysiology in a way that we could not do in the past. So in my mind, the discordance that we noted, which is improvement in imaging findings with improvement in serum transthyretin levels and improvement in NYHA class, with no changes on echocardiography, National Amyloid Center staging, or NT-proBNP, that discordance may reflect several points. First, it's possible that the molecular change detected by PYP reflects a change in the type of the fibril or fibril morphology, that becoming more mature and stable, but without actual regression of amyloid because the echocardiographic LV mass did not change or wall thickness did not change. Next, it's also possible that what we are seeing on the molecular imaging may be early changes, and this may be antedating eventual expected changes in cardiac structure and function, and that would be very exciting to know. So all in all, I do think that this study, even though it was small and limited to PYP, this really opens up a new era of personalized medicine for cardiac amyloidosis. We may be looking at an era where we are tailoring therapy to each patient based on response at a molecular level. And who knows, maybe soon we'll even be using targeted amyloid PET tracers where the mechanism of uptake is better defined and quantitation may even be superior compared to SPECT tracers. So a lot more work needs to be done. Very exciting area for research.
For sure. Your findings on echocardiography reminded me of one of the earlier trials with clinical trials, the phase 3 trials that were for registration of therapies, that also found a very minimal signal on regression of the disease by echo measurements. But if the signal gets better and the patients feel better, perhaps that is one thing to keep in mind to really assess what is truly relevant to patient care. Because at this stage, not only is the desire to improve survival, but also to make these patients feel better, right?
Yeah.
So just to conclude, what do you think is the future of PET? You've been doing a lot of work trying very different tracers. And I know you're heading now a very exciting new tracer for PET imaging. And what do you think will be the future of PET in cardiac amyloidosis?
Yeah, that's an important question, Marcelo, and thank you. Yes, so we are now participating And I'm the PI of the study looking at I-124 evusamitide for diagnosis of cardiac amyloidosis. This will be a very important study in the field. And if you think about it, this is the first time we have a radio tracer that's telling us specifically about one pathology, which is amyloid, right? So this could potentially be a test where you do one test and you tell the patient, yes, you have amyloid, or no, you don't have amyloid. So it's a very exciting field. PET tracers are more quantifiable, as you know, compared to SPECT tracers and quantification. So in the future, I would think that we could go along the lines of what you mentioned with oncology. You perform this test not only for diagnosis, but maybe you do a short-term follow-up to understand, is there a change? Is this patient responding to this specific therapy? If not, we may soon have multiple treatments options for ATTR-CM, and it's possible that if patient doesn't respond adequately to one therapy, maybe you will immediately consider switching to a next best therapy and avoid wasting time in terms of patients' clinical status getting worse. So lots of exciting new possibilities down the road here.
Definitely. Well, we'll end the conversation on that closing remarks that you have. In closing, I want to tell you that we are really truly delighted to be publishing your work and your team's work, and of course, would encourage you to keep this field moving forward. Especially in light of what you just said, which is the explosion of therapies for this very serious disease, for which we really need, more quantitative answers about target engagement, and also potentially now being able to triage patients from one therapy to another if they're non-responders. So thank you very much again for participating with us in this podcast.